Good morning, everyone. I want to thank the ICS for the opportunity to present this data. As far as disclosures, I have no financial disclosures with GTX, but this was sponsored by GTX Incorporated. So what do we know? We know the pelvic floor and urinary sphincter are very androgen receptor rich. And Nabisarm, which is the drug we're looking at, is a novel selective androgen receptor modulator. And it's been used in over 1,700 patients for other clinical trials and it's been very safe. We know that stress urinary incontinence is incredibly prevalent and impacts quality of life. And the purpose of this study was to look at this drug in a stress incontinent population to say, is there an opportunity to have an oral therapy for this disease? So just since we're urologists and gynecologists, I think we should know a little bit about SARM. But this particular SARM is a selective SARM, and it is a non-steroidal ligand, so there's no estrogen or progesterone receptor binding or activation. It's not aromatized to estrogenic metabolites. It increases muscle mass, strength, bone mass. It has positive effects on mood, energy, and libido, everything you'd want. And there's a very low risk for hirsutism or virilization. It builds pelvic floor muscles. And this is a rat study that shows that in an oophorectorized rat, if you look at the pelvic floor muscle mass, it reduces dramatically when you remove the ovaries. And then if you just give a placebo, there's no increase in muscle mass. But if you give the SARM, you see an increase in muscle mass. So that's what really led to this pilot trial, to evaluate the SARM in postmenopausal women with stress incontinence. Basically, it was a very low dose we used, 3 milligrams once a day for 12 weeks, and then patients were continued for a total of 40-week follow-up after stopping the drug. The primary endpoint is reduction in stress incontinent episodes per day, and we had a host of secondary endpoints that we'll show. So this is the key slide. 100% of patients met the criteria of improvement, which was a minimum of a 50% reduction in stress incontinent episodes. But actually, we found 83% reduction in stress incontinent episodes. It went from 5 to 0.8 incontinent episodes per day. And after stopping drug, the durability continued on for up to 7 months. This correlated great with reduction in pad weight. So, that's what you would hope for, right? Reduction in incontinence and reduction in pad weights. And so that correlated very nicely. If you look at our quality of life measures, the patient global impression of severity, at baseline, most patients had moderate or severe severity, and follow-up, most patients had mild severity or were considered normal. The UDI-6, IIQ-7 all fell dramatically, and then if you looked at patient global impression of improvement, the most patients showed improvement in their symptoms after treatment. So this, to me, was one of the striking things, was improvement in female sexual function index, and something that patients were very clear about when we met with them, is that the FSFI actually improved from a pretty significant low to what would be considered at week 12 a normal FSFI, and it probably is the impact it has on the sex hormone binding globulin. And so that's all great. I mean, this patient data looks great, but is it safe? And what we found is really it's been incredibly safe. There's been no serious adverse events. There was some very mild transient changes in some labs. You do see reductions in total cholesterol, LDL, HDL, and triglycerides. And importantly, the endometrial stripe was monitored and remained normal throughout this. So in conclusion, this is the first study ever to assess the role of a SARM in the management of stress incontinence. It had an excellent safety profile, really a profound effect on reducing incontinent episodes, improved quality of life, improved sexual function, and these improvements were sustained after stopping the drug. So the limitation, obviously, is there's no placebo in this, so currently now a placebo-controlled multi-dose study is ongoing. So I really want to thank the investigative team. It's been a lot of work to do this study, but I think we're all very excited about it. So thank you.
Any question? So, one question.
Yes.
Did you enroll only women sexually active?
No, and so that was just a secondary outcome measure, so not all women were sexually active, but that's one of the questions on the FSFI is, are you sexually active?
And which domains of the FSFI score were improved?
So we actually have just analyzed so far the total change in score. We haven't separated it out by domain.
Okay.
Yes?
Hi, Heidi Brown,
Hi.
US. This is really exciting. Thank you very much for sharing these data. Would you mind going back to your slide that showed the side effects? I'm just curious what women reported.
Sure. I don't know if I can go back because it's not up right now. But the side effects, there was a very transient, mild increase in liver function tests, which were not at all clinically significant. There was one patient who had a 1.5 times greater increase in it. Anyone who stopped the drug, there was only one patient we even felt we wanted to repeat it on, and it normalized after stopping the drug. You know, there were changes in HDL, LDL, triglycerides, so there were those changes. And then if you look at the other side effects, you know, there were some mild hot flashes, there was some, you know, headache, fatigue, but really all of them were very low grade and mild. I mean, this was, you know, we do lots of research. This was a very well tolerated drug.
Thank you.
Thank you.
All right, thanks.